Is in navigation-guided brain tumor surgery for both adults and children, and he will be delivering a talk with some slides as well this morning. So please put your hands together to welcome Dr. Essam Elgamal.
Thank you very much. Thank you for coming.
That one skips your slide. That one, yeah, we'll skip the slide.
Okay, thank you for the introduction. Actually, the management of brain tumor is changing every day. Since the last 3 or 4 decades has become really going with the advances in the technology. So I'm going to tell you what exactly is going on recently with the management of the brain tumor in general. So these are the things which we are as surgeons be involved in the management of brain tumors, like the stereotactic brain surgery, the brain mapping, intraoperative neurophysiological monitoring, the navigation-guided brain surgery, intraoperative MRI, robotic arm, and the use of robotics in surgery, MRI-guided laser ablation and laser interstitial thermal therapy, and the navigation-guided endoscopic brain tumor and skull base. So these are all new for the treatment of brain tumors. As you know, brain tumor is one of the common causes of death in adults, and the second most common cause of cancer-related death in children. So I operate in adults and in children brain tumors. In the past, they used to use this frame to take a biopsy from the brain, and they think this was the most advances in the treatment of brain tumors. There is a frame, cumbersome to fix it to the patient. You take the patient to the MRI, then you do the calculation till you reach to the XYZ point to take a biopsy from the tumor. But now we can use a frameless technique. So we have a navigation-guided brain tumor biopsy. We use a frameless technique, and it has a precise localization of the lesion, about 1 millimeter. Even if the lesion is 2 millimeter, we can easily take a biopsy from. These techniques, it helps us to reach to the tumor in the brain, avoiding important structures, not to cause any damage or injury to the tracts of the brain or the important centers or vessels around the brain, so we can reach to the lesion of inside the brain, taking the shortest route, reaching the tumor, taking it out, important parts of the brain. So if I'm going to close to the brainstem or within the brainstem or close to the nerves coming out of the brainstem, so I can monitor all the cranial nerves coming out of the brain during surgery, and the neurophysiologist will warn me if there is any irritation of this part of the brainstem or of the nerves, and I know when to stop, when to avoid any damage or causing any injury to the brain tumors. So you can just imagine how can we do the surgery using a frameless technique, navigation guided robotic arm reaching to a certain part of the brain within a short time, and precisely reaching that part of the brain, navigating through the brain, avoiding important and other structures. So this is an example of a lesion in the brain. How can we do brain mapping to just look at the areas around the brain and around the tumor, and the areas of the brain above the tumor, to avoid causing any damage to the brain, causing any damage to the centers of the brain. So we can take the tumor easily from the brain and keeping the normal structures undamaged or untouched. This is another slide for how can we use the robotic arm in reaching the part of the brain with the aid of the robot. So it helps us in reaching to a precise point of the brain to take a biopsy or to remove a tumor with, as I said, avoidance of causing any damage to the surrounding structure of the brain. Look at this lesion is within the center of the brain. So if we want to reach to that part in the brain, so it is in the middle of the brain, like in the hypothalamus. Hypothalamus is a part or a center of the brain that if you want to reach it, you have to go through all these parts of the brain. We have many cases who they present with like a precocious puberty or déjà vu seizures, and there is a way to treat these tumors by inserting a certain electrode in the tumor, taking the patient to the MRI, producing like a laser causing thermal damage to the tumor itself. So a simple operation, small hole in the skull, and implanting the electrode inside the tumor, then taking the patient to the MRI, and the thermal effect of the MRI with the tip of the electrode will cause reduction in the size of the tumor, death of the cells of the tumor, and the follow-up will show that the tumor had disappeared. So in the past, we used to do a major surgery. It takes about 12 hours to take this tumor out, and without trying to cause no harm to the surrounding brain. Usually these patients, they come up with a lot of complications. So this technique helps us to take the tumor out in a longer duration of time with a small operation.
Dr. Essam, if I can just interrupt, if you want, for better clarity, can you use the headphones? And if Dr. Essam, if you can speak more closer to the microphone, because I think people can't hear you. So if you want to listen in, you can wear the headphones for a direct feed. You can continue.
Okay. So I talked about the navigation guided surgery. So we use the navigation to take us from a point to another, similar to the GPS you use it in your trips. We feed the navigation or acquire the images of the patient on the navigation, and we can use another tool during the surgery like a skull-based endoscopic surgery. So a navigation-guided skull-based neuroendoscopy to take us through like the nose endonasal transsphenoidal surgery to reach to skull base. So you can remove tumors from the pituitary gland, you can remove tumors from the clivus, so you can do surgery through the nose of the patient aided by the neuronavigation guidance and the neuroendoscopy. Another things that we surgeons help the advent in technology helps us in doing surgery like the cyber knife, gamma knife, proton beam therapy. In the past, when patients come to us to take tumors out, we think about if I take the whole tumor out, the patient will do better. However, some tumors, you find the tumor is very much adherent to one of the nerves, brainstem, vessel, so you can leave a part of the tumor and you subject the patient afterwards for either cyber knife or gamma knife. Usually gamma knife helps in attacking the residual part of the tumor. So you do a good surgery for the patient, leaving a small part of the tumor, attach it to an important structure in the brain, and then you treat the patient after that by the gamma knife, and you save the nerve or you save that center in the brain. So cyber knife is designed to automatically adjust for movement, so you don't need to fix the patient during the cyber knife. While in gamma knife, you have to fix the patient and precisely just attack the lesion or the tumor by gamma knife. So you can give a high dose of gamma knife, single or once attack to the tumor, and the tumor will shrink. Like in common cases of acoustic neuroma, we can treat these patients by gamma knife. The tumor is small, less than 3 centimeters in diameter, single gamma knife radiation therapy for the patient, and the tumor starts to shrink. It takes about 12 to 18 months for the tumor to shrink, and the patient's symptoms improve. So we reserve the patient's hearing in most of the cases, and we reserve the facial nerve in all of the cases. This is another type of treatment, which is a proton beam. In the past, we used to give gamma knife gamma rays treatment or radiotherapy for children above 5 years of age. However, in proton beam, you can treat radiotherapy. You can treat patients less than 1 year of age by proton beam to avoid injury or damage to the important structures of the brain, and the side effects on the long term for proton beam is much less than if you treat the patient with gamma rays. So we surgeons help the medical oncologists in putting some wafers inside the tumor bed when we remove the tumor, which releases a chemotherapeutic agent to treat these tumors. And in the past, low-grade gliomas, which are benign tumor, it is named low-grade. However, usually it is in a malignant location. You cannot remove it all, and you can treat these patients, especially who they have a genetic mutation of BRAF V600E by these new drugs. When you give chemotherapy and when you put wafers producing chemotherapeutic agents inside the brain tumors, you can simply reduce the dose of radiation after that. So this is actually the wafers. You can put up to 8 wafers inside the brain tumor bed, and these produce the chemotherapeutic agents, and it will kill the tumor. Follow them up regularly, follow them up closely. If the tumor starts to grow again, then you can give radiation therapy in a smaller dose. Targeted therapy, this is the recent treatment of the brain tumors. These are the most recent 2 drugs that we are using them to treat gliomas, like the dabrafenib and trametinib. They produce effective treatment against the gene which has the mutation caused the growth of the patient's tumor, and they have less side effects than the radiation therapy, less side effects than the chemotherapy, and they have 4 times more effective treatment than the chemotherapy. And they improve the survival of these patients about 47% when you compare them 10% to radiation therapy and chemotherapy. So brain tumor management has changed recently, and there are many new technologies. I just don't want to go in details in it, but these are what we are using for the management of brain tumors in adults and in children, and we get very good results. We are very lucky actually to have the biggest tumor board in the country. Like in today we discussed 8 patients with brain tumors in the tumor board. So we have every week tumor board discussion for adults and children. We discuss between 5 to 10 patients, and we plan our treatment for them according to, as I said, the modern technology in the management of brain tumors. Anyway, thank you very much. Thank you for listening to me. Ready for any questions?
Thank you very much, Dr. Essam. If you've got any questions, please raise your hands and I'll bring the microphone over to you, and then you can address the questions to Dr. Essam. Any takers? Any conversations? Any questions? Right, I think that wraps it up. And if you've got any questions, you can do approach Dr. Essam right after the session. Thank you very much for joining us.
Thank you indeed.
Thank you very much to all attendees. If you'd like to check out more